Welcome to Healthcare du Jour, where we dish up and digest the latest in healthcare. For the next 30 minutes, sit back as we bring you insight, commentary, and discussion on trending topics to the table, all expertly served up by our host and his guests. Healthcare du Jour is brought to you by Carium, the telehealth platform enabling healthcare's digital transformation, helping you care for people within the fabric of their daily lives. Now here's your host, Matt Fisher.
Welcome back, and thank you for joining as we dive into the hottest topics in healthcare. I'm your host, Matt Fisher. On the menu today is Brian Petersen, Chief Scientific Officer at Podimetrics. Brian, welcome to the show.
Thanks so much for having me, Matt.
So, Brian, what I always like to do before getting into the main part of the conversation is give my guest a chance to give more of an introduction in terms of who they are and what they do. So the floor is yours. Sure,
yeah. I'm Brian Petersen. I'm a co-founder at Podimetrics in addition to the Chief Scientific Officer. Podimetrics is a technology-enabled services company, and we help patients and providers prevent diabetes-related amputations, which are one of the most debilitating and costly complications throughout all of diabetes. As a co-founder at Podimetrics, I think most co-founders would agree with this. You know, I wear a lot of hats, but I'm primarily responsible for the intersection of research and healthcare economics. And one of my most important responsibilities is ensuring that our products and services are evidence-based, that they're built in really good science so that we can best drive improved outcomes for our patients and strong financial return for our customers.
So I'm also always interested to know what first brought you into the healthcare arena.
Yeah, for me, if you can believe it, it was a bus ride. I actually started my career pretty far away from healthcare. I was trained undergraduate as a naval architect, and I spent the first several years of my career doing advanced design, simulation, analysis work for the U.S. Navy and DARPA as a defense contractor. And I was exposed to some pretty incredible technology and helped solve really engaging engineering problems during those first few years of my career. I'm a huge supporter of the military, and in fact, one of the most satisfying aspects of working at Podimetrics is the good work we do on behalf of the veterans with the VA. So I felt a lot of that same satisfaction as a contractor. But despite all that, after a few years, I was finding myself unfulfilled in my work. It was becoming too easy to focus on like all the incredible technology we're building and abstract away the application, the fact that essentially we were, helping to design and build weapons. And so when we would talk about working to silence a torpedo, for example, right, we'd talk about measures of success. We'd never really grapple with what success meant in that context. And the more I did that, the less comfortable I felt with it. And so I chose to go to grad school and pivot my career. I wasn't really sure what I wanted to do. I applied and was admitted to the Leaders for Global Operations program at MIT, which is a program that offers a dual degree, an MS and an MBA. And MIT has a pretty vibrant ecosystem for entrepreneurship. And one day I was on a bus, this is the infamous bus, with my classmate David Linders, who eventually became my co-founder at Podimetrics. And he starts asking me all these questions about how to use software, but he's being really vague about the problems. And we talked through those for 20, 30 minutes. And I finally asked him, man, what are you up to? And he explains, well, he had attended this hackathon called Hacking Medicine. And hackathon's basically just this event where folks with different backgrounds come together to identify problems, form companies, solve them, kind of similar to a business plan competition, except you compress all that good stuff into a weekend, right? So very little sleep. And anyway, he told me about, diabetic foot ulcers and how they didn't make sense and that they result in all of these needless amputations and cost. And that there's great research that suggests that you can easily predict and prevent them. And what David didn't know as he was explaining this to me is that my grandfather had actually had a foot ulcer. So unlike a lot of folks, I was already familiar and aware of the problem, but I didn't realize, like David, that they could be prevented. I love solving challenging problems with amazing people that can have outsized impact on the world. And this one seemed like it was, kind of fit into that mold, checked all the right boxes. And it's been this mind worm ever since. I've been, thinking about this problem since that bus ride for the last 10 years. And that's how I got into healthcare.
And it seems like if you're taking a bus ride in the MIT area, healthcare is definitely in the air there.
Oh, it is.
You're probably driving past what we, at that point in time, would have been called Partners. Now, obviously, Mass General Brigham with the brand rename. But there's always different forms of healthcare conversations happening in this area.
It's a buzz with energy. It's, Kendall Square, Technology Square. Harvard Square. There's just an enormous amount of enthusiasm for improving the world. And it's really a wonderful place to be because even if you're not feeling great that day, it's infectious, and it makes you want to go and create something and build something alongside the folks who are already doing it.
So what I'd like to do is, kind of circle back to one of the things you said early on, which was, that you help bring a science and evidence basis to the work at your company. How have you kind of developed that awareness and that understanding? Since, as you said, you didn't come from within the healthcare industry when you were first starting with the company.
Yeah, it's a good question. For me, being a lifelong learner is a really important thing. I think people should get good at things, and I think the first thing that people should get good at is getting good at things. Right? There's a virtuous cycle there. And with my engineering background, I was able to pick up a lot of the clinical study design and powering calculations and, how to be thoughtful about analyzing the data from those trials, how to read scientific evidence and make sense of it and challenge it and critique it and understand its limitations. Those are things that I actually was really excited to learn. I felt were extensions of the engineering background that I came from.
Yeah, and kind of focusing, as you said, on diabetes specifically, what were some of the key components that you've learned and helped drive your focus on, I think you were talking about, foot ulcers, but also, it sounds like a lot of the kind of helping to manage the complex diabetes conditions that folks might have.
Yeah. It's when you look at diabetes holistically, most of the cost and most of the opportunity to eliminate patient suffering and to save the healthcare system money derives from the treatment and management of complications related to diabetes, right? Diabetes is tough on so many of the body's systems, and these complications can be pretty devastating for patients. So for something like lower extremity complications and foot ulcers, the 5-year mortality following a foot ulcer is just shy of 31%. Following a high-level amputation, so an amputation at the knee, anything really above the ankle, the 5-year mortality is 56%, which is staggering when you put it in the context of things like cancer. Compare it to cancer, the 5-year mortality for breast cancer is 9%. And if you pool all cancers, the 5-year mortality is 30%. So we have this enormous problem related to advanced diabetes and its impact on lower extremities and limbs. And we're not talking about it. We're not organizing walks for the cure the same way we do for cancer, for diabetic foot ulcers and avoidable diabetes-related amputations, And then you look at the costs, Matt. The direct costs for diabetes in 2017 was about $240 billion. Some researchers suggest that 1 in every 3 of those dollars spent is actually spent on lower extremity care. And then you put that in the context of how much we spend on cancer, which is about $80 billion, and you take a third of 240, and all of a sudden you're like, wow, this is as big of a problem as cancer, in terms of the outcomes, in terms of the cost. And, there's this enormous opportunity there to improve those outcomes because those outcomes are not inevitable. Through good prevention, through systems like the one we're developing and commercializing at Podimetrics, through good evidence-based care from specialist providers like podiatrists, we can actually do significant good for these patients and bend costs in a really profound way.
And before, I guess, thinking about or diving into how to improve and drive better outcomes, let's go to the first stage and kind of what are some of the drivers or kind of root causes that you've discovered that lead to these severe complications?
Yeah, it's, I think, like most challenging problems in healthcare, there are a lot of factors at play, right? So first, if you just look at diabetes, prevalence is exploding. The latest CDC estimates that I've seen suggest that, more than 37 million people in the United States have diabetes. And of those, 8.5 million are undiagnosed. And then you kind of look at where that trend is heading. You look at folks who have prediabetes. Well, 1 in every 3 Americans have prediabetes. So this is a problem that's exploding in magnitude with respect to prevalence, right? So that's kind of the background of what's going on. Because we have such a large number of patients who are undiagnosed, right? Like, we know how to help patients with diabetes to manage their condition, in some cases even go in remission if they're very adherent to best practices around, living healthy lifestyles, eating healthily, losing weight. But if the patient doesn't know, and the provider doesn't even know that patient has diabetes, there's not much we can do. Right. So I think that's a big impediment, and I think that's a big factor for why this has become such an enormous problem. And when that diabetes is left untreated, either because there aren't good treatment plans in place for patients who are diagnosed, or because it's undiagnosed and we don't know to put good treatment plans in place, the diabetes, it damages blood vessels and nerves and the immune system. There are complications like vision loss, high blood pressure, heart attack, stroke, right? And again, all of these complications are what's driving the majority of the cost here. And are the real opportunities to improve patients' outcomes.
And kind of given what you just said of the rising prevalence of diabetes, along with kind of a corresponding rise in undiagnosed diabetes, have you been able to identify any strategies, or are you thinking about strategies to help drive earlier diagnosis, and so that way it helps to maybe mitigate against getting to a more complicated stage?
Yeah, as we think about, and again, we're focused on that very acute patient who has advanced diabetes, has had advanced diabetes for a while. That's going to be the patient who's at risk for diabetes-related amputations. As we kind of think along the risk spectrum, there's a patient with uncomplicated diabetes who has well-managed A1Cs and glucose levels. They're not really going to be a patient that Podimetrics is going to help, because they have much lower risk of developing those lower extremity complications than someone who has neuropathy and has lost protective sensation in the limbs, or has arterial disease and doesn't have good blood flow into the toes and feet, right? Those are the folks that, as we start to risk stratify out, that Podimetrics can really help and help have better outcomes, but also help the system save money on.
Right. No, and I think that's a great way to focus on what you're looking at and what you're doing to help as people have reached that more acute stage. But first, for those of you just joining, I'm talking with Brian Petersen of Podimetrics, and we've been kind of talking about the background of diabetes and the level of complexity. And as I just said, I'd like to now, as Brian, as you were just talking about, to hone in on, once you see that individual or that patient with an acute issue that's occurring, what kind of interventions or what kind of work can be done to, hopefully stop the continued progression, if hopefully that's an accurate assumption, before you get to a stage of amputation or other extreme intervention, because it's the complication has advanced so far that there is no other alternative.
Yeah, this is a really important part of what we do at Podimetrics, and a really important part of helping these patients achieve great outcomes is that intervention. And the great thing about that intervention is that it can be deployed in a timely way. We know when the patient needs it based on the information that we're collecting in the patient's home from the patient. So we know in a timely manner when the patient needs that intervention. That intervention, for the most part, is non-invasive, and it's inexpensive, and it's highly effective. So we have research that suggests that simply by offloading the affected foot, by removing pressure to the areas of damaged tissue on the foot before that foot ulcer occurs, that we can significantly reduce resource utilization. We did a partnership, a study with Kaiser Permanente that was published in one of the BMJ journals. And what we found was pretty remarkable, with this smart mat that lives in the patient's home, that the patient steps on for 20 seconds a day and sends data securely back to us for analysis, looking for those early signals that might indicate the patient's at risk. And then that simple intervention of calling the patient and figuring out, okay, well, what's the cause of that inflammation, that we were able to reduce the incidence of amputations by 71%. We were able to reduce all-cause hospitalizations by 52%. We saw a 40% reduction in emergency department visits and a 26% reduction in outpatient visits, right? And when you kind of roll all the resource utilization savings up, it amounts to a significant savings per member per year, between 8 and 13K, depending on what assumptions you make. So again, enormous opportunity to avoid these amputations, and then as a result, to save a significant amount of money as well.
And kind of based on what you were just describing, it sounds like a lot of it is centered around providing the patient tools that are easily usable within their own home, but then coupling that with real person intervention through technological means.
It's exactly right. There's a human element to what we do that we think is really important for driving engagement. And this is an area I think a lot of technology companies could do better work in. Gallup just released a poll, and like most previous surveys on this topic, nurses and doctors are at the top of folks and professions who Americans trust, right? And as an institution, healthcare, it has its issues, certainly, but it is one of our most trusted institutions. And technology does not enjoy those distinctions, and I think some of that's rightfully earned. And I think there needs to be a human element to the technology, right? We can do better for the patient with the right technologies, with the right measures and signals and monitoring. But that human element of helping the patient navigate the social determinants of health that they might face, and get the care that they need in a timely way, that's still best done, in our opinion, in my opinion, certainly, with that human touch and with that caring nurse on the other end of the phone, to really get those outcomes that we're looking for.
And I guess, as you've kind of continued to develop and refine your approach, have you been surprised, either positively or negatively, by how kind of the individual uptake and use of the tools that are provided to them in their homes?
Yeah, it can be a challenge. I think that it's important to help the patient develop anchor habits. And when you establish that anchor habit, you can build all sorts of amazing feedback loops for that patient to take better care of themselves, right? So what we'll do when we're working with a patient initially and trying to figure out where in the house do I put the foot mat that we send them, when am I going to use it? It's trying to figure out, okay, do you already have something that you do every day, right? Are you brushing your teeth at the same spot every day at the same time? Do you take your meds at the same time? Like what anchor routines exist? And if there aren't any, can we create one? And that can then be an anchor routine, not only for using the mat, but for using all of the other remote monitoring tools that you're availing yourself to, using that as an anchor to take your medication, right? Adherence to medication is a huge deal. And so, we're looking for those opportunities. And again, the human piece there, I think, is absolutely incredible. We could write instructions and quick start guides and offer all that information in an informal and personal way. That specialist on the phone to help the patient navigate that, and help them figure it out, what's going to work for them. I think that can't be understated for establishing those healthy routines.
Yeah. And I think, as you're saying, it's really about, in kind of strategically deploying technology to enhance the relationship between the patient and the care team, and not just think that the technology in isolation is going to resolve the issue.
I think that's exactly right, Matt. I think this is all about meeting the patients where they are. And I think a big piece of that is communicating the important information to the patients in a way where they're going to be most receptive to it. And sometimes it'll be technology. There are certain messages where technology is the right answer, but there are certain messages where, it's technology interpreted by another healthcare professional or by another expert or someone who's accompanying this patient through their disease progression, right? And I think that there's an enormous opportunity, not just to throw technology over the fence and into the home, but to see how it can enhance existing care pathways between the clinic and the patient. And that's what I'm most excited about. And that's what I've seen work best, at least for these chronically complex patients that we work with.
And kind of, as you just said, since you're working with a chronically complex patient population, do you see that it stabilizes things, or are you able to potentially drive improvement? So you're not just maintaining, not having to go down the more intense intervention route, but maybe backing up within the I don't know if saying backing up in the disease progression is the right way to characterize it, but
yeah,
is it a way to kind of reduce to some degree the severity?
It's a great observation, a great point. Often we find that patients, as they enroll in our program, they're bringing along a lot of baggage. And I mean that in a couple of different ways. First of all, many of them enroll in the program with a wound to one foot already. We didn't get to them early enough, and that other foot, that unwounded foot, is still at extreme risk. And so we can help that patient through coaching. We can help that patient get great care to heal the open wound on the left foot per se. And then on the right foot, which is unwounded, we can protect that foot while the left foot heals. And so, we see a lot of patients come into the program where, those routines aren't set up, those healthy routines aren't set up. And, we're dealing with the tail end of ulcers that occurred before the patient enrolled in the program. And we're helping them get to that kind of baseline level, which we can then build off of, a foundation that we can then build off of towards, even more improved preventive care.
Yeah, and I think that it seems to be a very important point that, as you said, if you can improve the preventive care, then, and actually you probably already said this, but it really then ties back to the overall cost savings, because if you're catching things earlier on or even stopping it altogether, then you're going to have less utilization, which means less spend within the system.
Yeah. And happier patients. Another big thing that we try to do and work with patients on, there's this concept in healthcare of locus of control. Just a fancy term. All it means is that do I, as a patient, believe that the things that I do actually influence my health outcomes? And for a patient who has had diabetic foot complications, previous foot ulcers, previous amputations of the lower extremity, that patient historically has a very low locus of control. They don't believe that the things that they do can impact the outcomes that they've experienced, right? And a big part of what we do at Podimetrics and try to do with the patient is to empower the patient and reverse that narrative. And as we've dug in, we've really understood where that narrative and where that low locus of control comes from. It comes from a failure of standard of care. A patient who just healed from a foot ulcer, they're going to be sent home, and what preventative standard care would currently recommend that they do is check their feet daily for changes, check their shoes daily for any changes. But you look at our patient, right? Pardon the pun, that's a very, very callous recommendation, because between 2/3 and 3/4 of our patients, depending on the study you look at, have vision impairment, comorbid vision complications from their diabetes. 95% are obese. The vast majority of them have limited joint mobility. Half are depressed. A third have dementia, right? Between 30 and 40% live alone. And so we're asking them to go home and to look at their feet, and they can't see and they can't bend their knee and actually look at the bottom of their feet in an effective way. Well, no wonder they think the outcomes that they're experiencing are inevitable, right? And that's going to really deteriorate, your empowerment with respect to the disease that you're facing. And what we try to do at Podimetrics is say, no, that these outcomes are not inevitable. With our device, we can detect much more sensitively than even your eyes would be able to detect these early changes that require interventions and will prevent those amputations and prevent those ulcers and prevent those bad outcomes that you're scared of. There was a study that was done, a survey of patients, and it found that patients actually feared high-level amputation more than death. And I think that's just a testament to how helpless they feel with respect to this disease state that's really ravaged them.
Yeah, and I think you just made two really important points, and both centered on that message of empowerment that you were talking about. The first one, at least in my opinion, was that if you're just discharging a patient and saying, monitor daily and look for these changes, that's shifting a lot of responsibility to detect what could, I think, as you're implicitly saying, could be very minute changes that would have very large impacts, but are going to be very difficult to see, even leaving aside the comorbidities that you identified.
Yeah.
But then if you can couple that with, we're asking you to help out from that perspective, but we're going to give you tools to enable that to occur. I think, as you're saying, all of a sudden now you can create this very positive framework around it where an individual is going to feel, oh, I am going to be able to get this done because I've got this support network around me that's going to probably drive me towards success.
Yeah, no, I think you nailed it. That empowerment piece is really crucial to what we do. And I think that, I suspect that there are a lot of other complications where patients feel similarly like, it doesn't matter what I do. And we need to be looking for technologies to make that not true. And then, again, the human element we can't leave out, because the technology alone likely won't convince that patient, like, no, this is actually different for you. This is going to be different this time around, and help again, push back against that narrative of helplessness and hopelessness.
Yeah, and I think kind of leaving on that note of empowerment is a perfect place to end, because believe it or not, we're already out of time. I want to thank my guest, Brian Petersen, for a great conversation today.
Thanks so much, Matt. I really enjoyed it.
And thank you to everyone listening. Keep the dialogue going and connect with me at #HCDEJURE. I'm Matt Fisher. Until next time.